Welcome back to the deep dive. Today we're embarking on a journey into the remarkable world of the equine heart,
Ah, yes.
an organ that's truly a marvel of power and efficiency, really built for peak athletic performance.
Absolutely.
When you think about it, a horse's heart is, well, an engineering masterpiece. It's designed to handle an astonishing range from maybe a peaceful resting rate of around 30 beats per minute
Very low.
all the way up to an incredible 240 BPM during a full gallop. I mean, what is it about this magnificent organ that makes it so uniquely capable of handling these extreme demands?
It's astonishing, isn't it?
Yeah.
The equine heart isn't just big. It's around 1% of a horse's body weight.
Huh.
So, a 1,000-pound horse is carrying maybe a 10-pound pump.
Wow.
And it's incredibly efficient. It can pump, get this, a staggering 1 liter of blood per beat.
1 liter.
Yeah, and boost that by nearly 50% during exercise. This tight B heart with its unique sort of diffuse electrical conduction system, it's really the engine room, the source of a horse's endurance and speed.
Right.
It allows for those really rapid increases in contractility that are vital for an animal that might need to, say, flee danger at a moment's notice.
It sounds like the ultimate athletic machine. But here's the surprising twist, maybe. This very engine of peak performance also holds a hidden vulnerability, a paradox we're about to explore.
Exactly.
While this organ is a mechanical and biological wonder, these unique adaptations can also create a specific substrate for certain rhythm disturbances.
That's the crux of it.
So our mission in this deep dive is to use your sources to unpack the essentials of these equine cardiac arrhythmias, specifically supraventricular arrhythmias. We'll explore what they are, why they matter, how they're diagnosed, and some of the groundbreaking treatments available now.
It truly is a unique challenge. This organ is inherently optimized for extreme athletic output, and that very optimization, while incredible, introduces specific vulnerabilities. It's fascinating.
Absolutely. So we've talked about its exceptional efficiency, its wide heart rate variability, and that rapid return to resting rate after exertion, which are actually key indicators of a horse's overall fitness, right?
Correct. Big indicators.
And that substantial musculature allowing for vast blood volume per beat is just incredible. But you mentioned a downside, a paradox. What do you mean that these adaptations can create a substrate for arrhythmias?
Exactly. So these adaptations, while enabling peak performance, can also set the stage for certain arrhythmias. What's intriguing is that some of these rhythm disturbances might even be considered, well, physiological when a horse is just resting.
Physiological, meaning like normal variations.
Sort of, yeah. Benign variations, almost a normal part of their super athlete physiology. But under the intense demands of athletic activity, they can become clinically significant. Problems can arise then.
Ah, okay. That distinction between physiological and pathological sounds absolutely critical. So for the physiological ones, are we talking about rhythms that don't really cause problems?
Precisely. Physiological arrhythmias generally have minimal hemodynamic consequences. Basically, they don't significantly disrupt the normal flow of blood through the body.
So no treatment needed, usually.
Typically, no. Think of sinus bradycardia, which is just a slow heart rate, or sinus arrhythmia, where the heart rate kind of waxes and wanes, or even sinus arrest, a brief pause in the heart's natural pacemaker activity, often because the horse's calming nervous system, the vagal tone, is working maybe a bit too hard.
Right, like in really fit horses.
Exactly. And the crucial characteristic here is that they tend to resolve or just disappear with increased stimulation, like excitement or exercise.
And a classic example of that is something many horse owners might have heard of. Second-degree atrioventricular block, AV block.
Very common.
Yeah, very common in fit horses. It's a temporary interruption where the heart's prep signal, the P wave, isn't always followed by the main pump, the QRS complex. But like you said, it typically resolves with exercise or excitement.
Right. But then you contrast that with pathological arrhythmias. Now, these are different. They're indicators of significant underlying cardiac disease or maybe systemic illness.
Okay, so these are the serious ones.
Definitely. They're associated with decreased cardiac output, hemodynamic instability, and they can potentially lead to more severe, even life-threatening arrhythmias. This is why the distinction matters so much.
So just listening at rest isn't enough.
No, relying solely on a resting exam risks misclassifying benign rhythms or, even worse, missing those exercise-induced pathological ones that directly impact performance and, frankly, safety. Simply identifying an irregular rhythm isn't enough for a diagnosis. You need more information.
It's fascinating how the very design that makes horses such incredible athletes can also predispose them to these unique cardiac challenges. It really necessitates such a nuanced diagnostic approach.
That nuance is absolutely key. You really have to look at the whole picture.
So let's go a layer deeper into supraventricular arrhythmias, or SVAs. What exactly are these, and which ones should we be paying closest attention to?
Okay. SVAs are rhythm disturbances that originate above the ventricles. So, specifically in the atria or the atrioventricular node, the AV node, this group includes things like atrial tachycardia, atrial flutter, and the big one, atrial fibrillation.
And you sometimes hear about premature beats.
Right. When we talk about isolated premature complexes, we call them supraventricular premature depolarizations, or SVPDs. If you get more than 4 SVPDs in a row, that's a supraventricular tachycardia, or SVT. And that can be paroxysmal, meaning it comes and goes, or it can be sustained.
Okay. And from what I understand, atrial fibrillation, or AFib, that's the big one here. Why is that?
It is arguably the most important in this group. It's the most common, clinically relevant, and performance-limiting cardiac arrhythmia in horses.
And what does it look like or sound like?
It's characterized by an erratic, irregular rhythm. You listen, and there's no pattern to the irregularity. The atria are beating rapidly, chaotically, totally out of sync with the ventricles.
Its pathophysiology sounds complex. You mentioned something earlier about AF begets AF, which sounds a bit chilling. Can you explain that?
Yeah, it's a complex dance, really, within the heart. It's a combination of electrical misfires, these triggers, often atrial premature depolarizations, APDs, from things like altered automaticity or micro-reentry,
Right.
and a heart muscle, an atrial substrate that's unfortunately primed to keep those misfires going. And AF begets AF isn't just a clever phrase, it's a chilling reality. Imagine a glitch in a system that every time it misfires, actually rewires itself to misfire more.
Wow. So the arrhythmia itself changes the heart tissue.
Exactly. It causes electrical, contractile, and structural remodeling of the atrial myocardium. That's why, with AF, early intervention isn't just good practice. It's a race against the heart's own, well, self-sabotage.
That makes perfect sense why timing is so crucial. So what causes AF then? And are some horses more prone to it?
Well, the predisposing factors are varied. You can have lone AF, where there's no detectable underlying cardiac abnormalities. It just happens.
Idiopathic, right.
Right, idiopathic. But it can also be secondary to underlying cardiac disease, things like valvular insufficiency, leaky valves, or chamber dilation, atrial enlargement.
Anything else? Electrolytes, maybe?
Yes, definitely. Electrolyte imbalances, like transient potassium depletion from colic or heavy sweating, are known contributors. There's even some evidence of a genetic predisposition, noted particularly in standardbred racehorses.
Interesting.
And certain medications, things like sodium bicarbonate supplements, milkshakes, thyroid hormones, or even furosemide can sometimes trigger it.
Okay. Beyond AF, there are other rhythm disruptions that can quietly undermine a horse's performance. Let's touch on atrial tachycardia next. You said it's rarer, but can be just as insidious.
That's right. Atrial tachycardia, or AT, it stems from one or more ectopic foci, basically, rogue electrical spots in the atria. It presents with a regular rhythm, but a significantly elevated heart rate, often starting and stopping abruptly.
And on the ECG?
On an ECG, you'll see a distinct P' wave, we call it P, followed by a normal QRST waveform. The challenge in diagnosis, though, is that a surface ECG often struggles to differentiate it from just a normal fast heart rate, physiological sinus tachycardia.
So you need more than just a quick resting ECG.
Absolutely. You often need Holter monitoring, that 24-hour trace, to catch it. And this difficulty implies that subtle performance issues in athletic horses might actually be undiagnosed AT. The good news, though, is that it can often be treated with radiofrequency ablation.
Okay. And what about premature atrial contractions, or PACs? I've heard those are quite common. Are they usually a problem?
PACs are simply electrical impulses starting in the atria that occur earlier than expected. Their clinical significance really varies. Often they're benign, totally incidental findings.
But not always.
Not always. If they're frequent, say, 1 to 5 per minute consistently, or they seem to affect performance, maybe leading to a high heart rate or predisposing to episodes of AF, then they might indicate underlying atrial disease. On an ECG, you see a premature P wave, and if it conducts down to the ventricles, a normal QRS, often followed by what's called a non-compensatory pause.
Got it. And atrial flutter, is that distinct from AF?
It is, although sometimes it can look similar on just listening. Atrial flutter can also present as an irregular rhythm on auscultation, like AF. But on the ECG, you'll typically see a characteristic sawtooth baseline. That's due to rapid but more organized atrial activity compared to the chaos of AF, and it can actually progress to or from AF sometimes.
Okay. And the other SVAs you mentioned briefly, SVPDs and SVT.
Right, so supraventricular premature depolarizations, SVPDs, they're common but often incidental, like pixies. They're rarely of immediate clinical significance during or after exercise, but again might be a risk factor for developing AF later. Supraventricular tachycardia, SVT, that run of fast beats, is uncommon, but can certainly be associated with poor performance if it happens during exercise.
It's truly astounding how these, subtle sounding changes in rhythm can have such a profound impact on an animal designed for such incredible physical feats. What are the clinical signs you typically see, and how might they manifest differently in, say, a racehorse versus a show jumper?
Yeah, the clinical signs of SVAs can range from extremely subtle to, unfortunately, life-threatening. The most common complaint, especially in athletic horses, is poor performance or exercise intolerance.
Like what specifically?
Things like reduced stamina, getting tired really easily, maybe suddenly decelerating during a race when they shouldn't, just not having that finish.
I can imagine the frustration for an owner or trainer when their top athlete starts underperforming and the cause isn't obvious, like, a lame leg.
Exactly. That's a huge challenge. Other signs can include respiratory issues, shortness of breath, dyspnea, sometimes coughing, or even nasal discharge after hard work. In more severe cases, you might see weakness, lethargy, or rarely collapse or sudden death, particularly during really strenuous exercise.
Any less common signs?
Less common signs can include things like nosebleeds during exercise, epistaxis, and sometimes just subtle behavioral changes that the owner picks up on.
And diagnosing it sounds tough.
It is indeed a real diagnostic challenge, especially because many cases, like that lone AF in non-competing horses, they might be totally asymptomatic at rest. It's only found incidentally during a routine checkup.
Right.
And the nonspecific nature of the signs, poor performance, being a bit off, often leads to delayed diagnosis or people blaming other things, like musculoskeletal problems. So you really need a high index of suspicion for cardiac causes in performance horses showing these signs.
And the impact on performance isn't a one-size-fits-all, is it? It depends on the horse and the job.
Not at all. It's highly dependent on the arrhythmia type, the severity, the athletic discipline, and of course, any underlying heart disease. A racehorse might show very overt signs with AF because the demands are so high.
Whereas maybe a jumper.
Right. A jumper might only have a moderate reduction in performance initially, which can really delay diagnosis. So the significance of finding an arrhythmia changes drastically between, say, a pleasure horse and a high-level eventer or racehorse.
And the underlying causes, you mentioned electrolytes, but what else?
The underlying causes and risk factors for SVAs can include things like hypoxia, low oxygen, maybe from lung issues, sepsis, toxemia, certain drugs. And it's a fascinating nuance here that quinidine sulfate, which we'll talk about as a treatment for AF, can sometimes cause SVT itself.
Huh, interesting paradox.
Yeah. Also autonomic imbalance, metabolic or electrolyte imbalance, as we mentioned, and primary myocardial disease. Risk factors often involve underlying structural issues, mitral or tricuspid valvular disease, congenital heart problems leading to atrial enlargement, and sometimes infective endocarditis.
Okay, so we know the signs can be subtle, the causes varied. How do we actually figure out exactly what's going on? What's the detective work involved in diagnosing these subtle but significant issues?
Well, accurate diagnosis really relies on combining a thorough clinical examination with more advanced imaging and electrophysiological techniques. It's truly a multimodal approach. You need to build a complete picture.
And where do you even begin that detective work? What's step one?
Step one is always a comprehensive physical and cardiac examination. That means good auscultation, carefully listening to the heart for rate, rhythm, any pauses or extra sounds like murmurs, and palpating the peripheral pulse, often the facial artery, to check for pulse quality and deficits.
Anything else you look for on the physical?
Yeah, checking for jugular vein distension or excessive pulsing can also be an indicator of potential heart failure. But while it's foundational, a physical exam alone is often insufficient for a definitive diagnosis, especially with those physiological variations or rhythms that only pop up under stress.
Right. That's where electrocardiography, the ECG, comes in as our electrical map, right?
Precisely. A resting ECG is key to confirm the diagnosis, evaluate the heart rate and rhythm in detail, and detect any abnormal electrical complexes. The base apex lead configuration is typically the most useful in horses for visualizing atrial activity.
But there are limitations with ECG in horses compared to humans.
Yes, that's a really important point. Unlike in humans, where an ECG can give us a good sense of heart chamber size, a horse's incredibly extensive and diffuse electrical wiring, its Purkinje system, means the QRS complex amplitude doesn't reliably correlate with chamber size.
So you can't just look at the ECG and say, oh, the left ventricle is enlarged.
Exactly. It's like trying to judge the size of a mansion. Just by looking at the complexity of its electrical panel, it doesn't give you the full picture of the structure.
Okay, that's a really important distinction for listeners to grasp. So if a resting ECG isn't always enough, how do you capture those elusive, stress-induced arrhythmias, the ones that only happen during exercise?
That's why dynamic assessments are so vital. An exercising ECG is really indispensable for differentiating physiological rhythms, which should resolve with activity, from pathological ones, which might appear or actually get worse during activity. It can also reveal things like an exaggerated heart rate response in horses with AF.
And for catching things that happen intermittently.
For that, the gold standard is 24-hour Holter monitoring, or ambulatory ECG. This gives us a continuous recording of the horse's heart rhythm throughout its daily routine, including rest, feeding, turnout, and importantly, during exercise. It's invaluable for capturing those intermittent episodes that might only happen once or twice a day, and for assessing the true resting heart rate and arrhythmia frequency.
And technology's helping here too, right? With portable devices.
Absolutely. We now have excellent smartphone-based ECG systems like AliveCore's KardioMobile. These are portable, surprisingly accurate, and incredibly useful in field settings for quick checks or monitoring during specific events. These dynamic, real-world assessments represent a huge advancement from just taking static snapshots at rest.
Okay, so we have the electrical picture, then we move to echocardiography, the ultrasound, to get the structural and functional view.
Exactly. Echo is indispensable. It's an ultrasound of the heart that lets us assess both structure and function. Structurally, we visualize heart size, measure chamber dimensions like left atrial size, which is critical for AF prognosis, and assess the integrity and function of the heart valves. This is absolutely crucial for differentiating lone AF from AF that's secondary to underlying structural abnormalities.
And functionally.
Functionally, it helps us identify any chamber dysfunction, like poor contractility, and quantify the severity of any valvular regurgitation and leaky valves. And practically, it's essential for guiding interventional procedures, like transvenous electrical cardioversion, TVSC, which we'll talk about.
So echo gives context that the ECG can't.
Precisely. It provides the anatomical and functional context that ECG alone cannot. This is vital information for determining prognosis, selecting the best treatment, and estimating the risk of the arrhythmia coming back.
So with the electrical signals mapped by ECG and the heart structure visualized with echo, are there any other pieces of the puzzle we might need for a complete picture?
Definitely. Ancillary diagnostics play a role too. Blood work is important. A complete blood count, CBC, biochemistry panel, blood gas analysis, and electrolytes. These can help detect underlying systemic diseases like sepsis or myocarditis, or identify electrolyte or acid-base abnormalities that could be causing or worsening the arrhythmia.
What about markers for heart muscle damage?
Yes, measuring cardiac troponin I, CTNI, can be very useful. Elevated levels can indicate myocardial inflammation or damage, which might be contributing to the arrhythmia. And then for highly specialized cases, there's advanced electrophysiological mapping, like 3D electroanatomic mapping, or EAM.
Wow, that sounds complex.
It is. It provides incredibly precise information on the exact location of the electrophysiological abnormalities within the heart chambers, guiding very targeted interventions like radiofrequency ablation. But that's usually reserved for referral centers. Really, the evolution of these diagnostic tools, from just simple auscultation with a stethoscope to sophisticated 3D mapping, truly highlights the commitment to understanding the subtle intricacies of these powerful athletes' hearts.
That commitment absolutely carries over into treatment, which seems like a fascinating area of rapid advancement itself. So what are the general principles of treatment when we find one of these arrhythmias? When do you decide to treat?
Well, a holistic approach is paramount. It's really about diagnosing and correcting any underlying cardiac issues or even non-cardiac diseases before you jump into antiarrhythmic therapy, or at least concurrently. Treating the root cause is always key for long-term management.
And timing matters, you said, especially for AF.
Yes, early intervention is crucial, particularly for atrial fibrillation. Remember that AF begets AF phenomenon. The longer AF persists, the less likely successful conversion back to normal sinus rhythm will be achieved and maintained. because of that progressive remodeling of the atria.
So when do you typically recommend specific antiarrhythmic therapy?
Generally, it's warranted when the arrhythmia is associated with clear clinical signs, when it compromises hemodynamics, meaning it affects blood flow and cardiac output, or when it indicates a significant risk of developing more severe, dangerous arrhythmias.
Okay. So let's talk specifics. What's the go-to drug, historically at least, in the pharmacological therapy toolkit for something like AF?
Historically, quinidine sulfate has been the primary drug of choice for medical conversion of AF in horses. It has a pretty decent efficacy rate, around 85% in some studies.
How does this work?
It's a sodium channel blocker. Basically slows down electrical conduction in the heart and prolongs the refractory period, the recharge time for the heart cells. This helps interrupt the chaotic circuits of AF. It's typically given via a nasogastric tube, often every couple of hours, until conversion or side effects occur.
Side effects. You mentioned toxicity earlier. That's the big drawback.
Yes, here's the crucial caution. Quinidine has potential for severe toxic side effects, and these become more likely with increasing doses needed for conversion. These can range from ataxia, walliness, nasal edema, swelling, colic, hives, laminitis, and sadly, rarely even death.
Wow.
It also carries risks of actually causing other arrhythmias, like a dangerously rapid ventricular response rate or ventricular ectopi. So this significant toxicity profile has really driven the search for safer alternatives over the years.
That's a serious list of side effects. It certainly makes you want to look for other options. What about digoxin? Where does that fit into the picture?
Digoxin is primarily used for supraventricular arrhythmias, especially those with very fast heart rates. It helps slow the conduction through the AV node, controlling the ventricular rate. It's often used as a pre-treatment for horses with chronic AF or atrial enlargement, or sometimes during quinidine treatment to prevent excessively fast heart rates.
But it has its own issues.
It does. It requires careful monitoring because its pharmacokinetics can be variable between horses, and it has a narrow therapeutic window. The dose needed for effect isn't far from a toxic dose. And like quinidine, it also has the potential to induce arrhythmias itself. So careful monitoring is key.
And are there other drug options that are commonly used, or is it mostly focused on quinidine and digoxin for SVAs?
There are other drugs explored with varying success and side effects. For example, sotalol, which has beta blocker and potassium channel blocking effects, looks promising for maintaining sinus rhythm after AF cardioversion and for chronic treatment of both supraventricular and ventricular arrhythmias. It seems to be reasonably well tolerated orally.
What about others?
Imiodarone has been used for short-term IV conversion of SVT, but recurrence seems to be a concern after stopping it. Other drugs like flecainide have shown minimal efficacy for chronic AF in horses, and sudden death has even been reported, so it's not widely recommended. And propafenone is another one that's not currently recommended due to lack of efficacy and a high risk of inducing severe, potentially fatal arrhythmias in horses.
Okay, so given the challenges and risks with some of these drugs, particularly quinidine, what's been the real breakthrough, the game changer in treating AF specifically?
That would undoubtedly be electrical cardioversion, specifically transvenous electrical cardioversion, or TVSE. It's been a truly significant advancement for AF treatment in horses.
How does TVSC work?
It's a procedure where specialized electrode catheters are placed directly into the heart, usually via the jugular vein in the neck. Their position, typically one in the right atrium and one in the pulmonary artery, is guided by echocardiography. Then, a synchronized electrical shock is delivered across the atria. This is all done under general anesthesia.
And the success rates?
The success rates are incredibly high, up to 98% reported, for converting AF back to a normal sinus rhythm. What's more, it's effective even for horses that haven't responded to quinidine or those with long-standing AF.
Wow, 98% is impressive. What makes TVSC so much more successful, and what are the advantages over quinidine?
A major advantage is significantly fewer systemic complications and a much reduced risk of toxicity compared to high-dose quinidine. Also, unlike in humans where stroke is a risk after cardioversion, there appears to be no significant risk of thromboembolism or blood clots in horses after TVS.
Are there any risks with TVSC?
The primary risks are really those inherent to any general anesthesia procedure in a horse. And very rarely, a fatal ventricular arrhythmia can be induced by the shock itself, but this is uncommon. Because of its high success rate and better safety profile, TVSC is often considered a preferred first-line treatment now, especially at referral centers. It marks a notable shift in the standard of care.
That's a huge step forward for equine health. And what about those highly targeted solutions you mentioned for specific localized problems, like some atrial tachycardias?
Right, that's radiofrequency ablation, or RFA. This is a highly targeted, potentially curative approach for specific, localized atrial tachycardias where the faulty electrical circuit is well defined.
How does that work?
It involves sophisticated mapping techniques like that 3D EAM we mentioned to pinpoint the exact arrhythmogenic substrate, the tiny area of heart tissue causing the rhythm problem. Then radiofrequency energy is delivered through a catheter to essentially cauterize and destroy that precise spot.
So it fixes the source.
Exactly. But it requires highly specialized equipment and expertise, so it's definitely a more advanced procedure for specific cases. It's truly like electrical surgery on a micro level.
Okay, so whether it's drugs, TVSC, or ablation, after a successful intervention, what happens next? Monitoring must be key.
Absolutely. Post-treatment monitoring and management are crucial for long-term outcomes. For short-duration arrhythmias that are successfully converted, return to work can often be initiated quite rapidly. But for more long-standing cases, it needs to be a more gradual process.
And how do you monitor? Back to Holters.
Yes, ambulatory ECG recordings like 24-hour Holter monitoring are invaluable after treatment. They help confirm that the normal sinus rhythm is being sustained and allow us to detect any early recurrence of the arrhythmia. For horses with persistent AF, where cardioversion wasn't successful or wasn't an option, monitoring heart rate during exercise is really important to help modify their work intensity to a safe and appropriate level.
So pulling it all together, what does this all mean for the horse and its future performance? What does the road ahead look like after a diagnosis?
Well, the prognosis is influenced by several key factors. The arrhythmia type and its duration are really important. For AF, as we've said, the longer it has persisted, especially if it's been more than about 4 months, the less likely successful conversion and maintenance of normal rhythm will be achieved. That's due to that electrical and structural remodeling.
Right, the AF begets AF effect.
Exactly. And paroxysmal AF, the kind that comes and goes, can unfortunately progress to a permanent form over time.
So it sounds like time and any existing damage are massive factors. Can you paint a picture of how those variables specifically influence what we can expect for a horse's future?
Absolutely. The presence and severity of underlying structural heart disease is probably the biggest factor. Horses with significant chamber dilation, like an enlarged left atrium, or significant valvular insufficiency leaky valves, generally have a poorer prognosis for successful conversion. And they definitely have higher recurrence rates if conversion is achieved.
And in really bad cases.
In complicated cases with severe underlying disease, the prognosis for just overall quality of life, let alone performance, can even be guarded to grave. And of course, the athletic demands placed on the horse play a huge role. While a horse with untreated AF might live a normal life expectancy just hanging out in the field, its athletic career is almost always significantly impaired. So prognosis is truly a spectrum, requiring really individualized assessment for each horse in its situation.
That brings us to the big question for owners. Return to performance rates. What can they realistically expect after treatment?
For lone AF, remember that's AF without detectable underlying cardiac abnormalities, horses generally have a good prognosis for returning to their full athletic potential if normal sinus rhythm is successfully restored and maintained.
Especially with TVAC.
Yes, specifically with TVAC treatment, most studies show that the majority of horses achieve complete recovery and return to their previous level of athletic performance. And again, treatment within about 4 months of the AF onset significantly increases the likelihood of a positive response and that return to previous performance levels.
What about horses that aren't treated or can't be?
For untreated AF, horses at rest or maybe brood mares typically have a normal life expectancy. But their athletic capabilities are definitely compromised. They usually can't perform at high levels. And for things like PACs, those premature atrial contractions, they're generally not considered dangerous for athletic performance if there's no structural heart disease found and no associated clinical symptoms.
Okay. But recurrence sounds like it's always lurking in the background, even after successful treatment. Is it a lifelong battle for some horses?
It can be, yes. Recurrence is a definite concern. For AF, recurrence rates after successful cardioversion generally range from maybe 10–15% in uncomplicated cases, but overall rates, including horses with underlying issues, can be as high as 40% or more in some reports.
Wow, 30% is high.
It is. For lone AF of less than about 1 month duration, the recurrence rate is lower, maybe around 15%. But factors that significantly increase the risk of recurrence include chronic valvular disease, atrial enlargement, especially a large left atrium, having excessive PACs or SVPDs before or after conversion, and having had previous unsuccessful conversion attempts.
So for some horses, it's not really a cure.
Exactly. This potential for recurrence, especially with underlying structural heart disease or long-standing arrhythmias, really necessitates ongoing vigilance and tailored long-term management plans. It shifts the paradigm for some affected horses from thinking about a one-time cure to more of a chronic disease management model.
Right.
And as we mentioned, for horses with persistent AF, where cardioversion isn't an option or fails, careful monitoring of heart rate during exercise is crucial to adjust their work intensity appropriately. And frankly, if significant underlying heart disease is present, the prognosis for long-term athletic function is often guarded to grave, and any treatment response might only be transient.
It certainly raises profound questions.
It really does. It raises an important question. How much more can we refine our understanding of these incredibly intricate cardiac systems? And what could that increased understanding mean for predictive health, not just for our equine athletes, but potentially across species?
That's a fascinating thought to end on. So, to recap this deep dive, equine supraventricular arrhythmias, especially atrial fibrillation, represent a significant and complex challenge, particularly impacting our athletic horses. We've seen that while some arrhythmias are physiological, maybe even normal for fit horses at rest, pathological forms can severely compromise performance, welfare, and even safety.
And diagnosing them accurately relies on that comprehensive, multimodal approach, combining thorough physical exams, advanced ECG techniques like exercising ECG and Holter monitoring, and crucially, echocardiography to assess both the electrical activity and the heart's structural integrity.
Right. And treatment strategies have evolved considerably, haven't they? Moving from primarily quinidine-based pharmacological interventions, which carry those significant risks we discussed.
To the highly successful transvenous electrical cardioversion, TVEC, which really offers superior outcomes and a much better safety profile, especially for AF.
It seems clear that early diagnosis and prompt intervention are absolutely critical for maximizing the chances of successful conversion back to normal sinus rhythm and hopefully facilitating a return to athletic function, especially for those lone AF cases without underlying disease.
Definitely. However, we have to remember that the presence of underlying cardiac disease or arrhythmias that have been going on for a long time can really complicate the prognosis. It often necessitates those individualized, long-term management strategies, acknowledging that some cases may transition into more of a chronic disease management model rather than achieving a definitive cure.
Indeed. So, considering the remarkable adaptations of the equine heart for peak athletic performance and our constantly evolving ability to diagnose and treat these complex arrhythmias, what deeper questions does this raise for you about the limits of biological systems? And how can understanding these intricate details in horses help us better care for other athletes, maybe even ourselves, in predicting and preventing similar conditions?
That's the million-dollar question, isn't it? The horse is such an incredible model for exercise physiology and cardiology. Understanding how this amazing heart works and how it sometimes goes wrong under pressure could absolutely hold clues for athletes of all species, the fascinating frontier.